You're welcome back. This is Newsfile, it's your most authoritative news analysis platform. And here on Newsfile, we put Ghana first. And joining us in the studio is Nana Kwabena Abrampa Mensah. He's team leader, security sector governance and local and urban governance of the CDD Ghana. Thank you very much for joining us. We'll have others join us on Skype. So let me now go to, okay, so we also have Dr. John Amwesi, lecturer, Global Health Department, School of Public Health, KNUST, and leader, Global Health and Infectious Diseases Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine, KCCR. Join us. That's Dr. John Amwesi. Doc, thank you very much for joining us via Skype.
Thank you very much.
Great. You have been very helpful in giving us the needed education and to how to protect ourselves as well. Now, let me begin with Dr. Titus Breyuo. Where we are now, from when we announced the measured lockdown, is a total lockdown imminent?
Good morning, Samson, and good morning to our viewers. I would say that it's pretty early to make the call. We need a lot of sound epidemiological data to make that call, and I think we are reviewing the data. Some of the information that may inform that call or otherwise will be the increase in cases and the trend of the cases. If the cases continue to be in the areas of the lockdown and they are under control, then it wouldn't be necessary to escalate further. So I think pretty soon a lot of analysis is being done, and when that data is complete, the president will be advised appropriately. But I think it's too early to project that a total lockdown is imminent. I think it's too early.
Right. Now, you are in your face mask.
Yes.
We're beginning to see that across the globe, that is becoming the new advice. Is that what Ghana is also seeking to adopt?
Well, so I would say that if you have it, you should use it, especially if you are having symptoms of respiratory symptoms. The mechanical barrier bit of it, we cannot rule it out. Currently, the WHO says there is not enough evidence, but not enough evidence doesn't mean there's no evidence at all. There is by all means evidence to show that as we sit closer to each other and communicate, droplets will come out. Even in exhaling, droplets come out. And so when the person is within close proximity to you, that risk is there. In some environments, however, it is even more predominant. I am using mine because I'm on duty today in the hospital, and I've been on it throughout. And so when I'm in patient areas, I use it. When I'm in the public, where I think I come in contact with people, I use it. And I think everybody who has it should use it. If you don't have it, you shouldn't panic, especially if you are not going out. If you are locked down in your home, it may not be necessary. But I should give the golden rule about using the mask. I have observed how people use it, and it is very dangerous.
Right.
The golden rule, it must be on or off, not hanging. So that hanging phase just defeats the entire purpose of the mask. So you see people wear it, and then when they want to talk, they take it off and drop it on their chest. What it means
I've seen a good number of the security personnel who are, you know, implementing the lockdown
do that.
The same thing. They
Exactly.
go to a trotro driver, they remove it before they begin to speak.
Yes. And then a lot of people at some point in time will just drop it on their chest and then be walking around doing everything normally and later put it on again. It just contaminates the whole thing. So assuming that somebody gets close to me and talks to my face, and there are droplets on this thing now, if I remove it and leave it on my chest, it just contaminates this upper part of my body. And then I pick it again and wear it, and even the surface which is within now would then be exposed in the way they drop it sometimes. So I think it's on or off, and off means you discard if it's a discardable one, or if it's one that can be reused. Then when you take it off, there's a way we preserve it so that the inner surface doesn't get contaminated, and then you can reuse it. And then there are different types of masks for different purposes, and so I'm sure
we likely have people who are using the one that they can reuse.
Yes.
How do you ensure that it's in the best shape to reuse.
Yeah.
How do you put it on first, and how do you remove it?
Okay, so there are different varieties. What I'm using now may not be the very best example to use to teach people. The commonest one that I see people have is the one that has two strings, two pairs of strings, one up and then the other down. If you are fixing it, you should hold it straight up that way, bring it to your face. There is a metal strip in here that you can bend to form a curvature around your nose. You do that and then fasten the top one and then fasten the second. When you are removing it, if for that one is disposable, you just remove the whole thing and discard it. We have seen some people use the N95. I've seen some parliamentarians use it in parliament, which is what we actually need to work and we are not getting. This is an example of the N95. If you are using the N95, which is reusable, when you are taking it off, first thing is to make sure the inner surface, which is the part that touches your nose and your mouth, doesn't touch anything else. So there are people use disposable or plastic bowls to preserve it. You remove it, preserving that inner surface into the bowl and then cover it so that that surface never gets contact with anything. When you are wearing it, you hold it by the string, hold onto the part of the nose where you've pinched, and then fix it directly onto your face, and then you fasten.
We've seen some market women, they are pulling it off and all their hands are over it, you know.
So it is unfortunate.
And they pull it back.
It's unfortunate.
And they are serving people in the market.
So that was why I think about 3 weeks ago, I made a statement here that the masks give a sense of false security if you do not know how to use it, and it actually can be more harmful to you.
All right.
If you are using the same mask for a week, pulling it out and down, bringing it down, and then refixing it all the time, you're using your hand on it all the time, then it becomes a reservoir for bacteria, and it traps a lot of organisms, and even this COVID virus, it can trap it there, and eventually you just inoculate the virus into yourself. So the critical thing is to know the type of mask you are using and know that it's either on or it's off. And if it is off, if it is reusable, preserve it well. If it's not reusable, discard it once you take it off. Don't leave it hanging on your shirt and then or your neck and then put it back. That is dangerous.
Okay. Dr. John Amwesi, what would you say? Are we supposed to, as it were, improve the protection that we are supposed to take? Moving from washing our hands, using the hand sanitizers, ensuring social distancing, not touching our faces, not touching our nose, eyes, and so on. And then, in addition to that, wearing the masks.
Thank you very much, Samson, and greetings to all your listeners. It's a pleasure to be able to come to you again. I think the submissions by Titus are really in line with the current global thinking around ways to prevent the spread of the disease. And the advice regarding hand washing, the advice regarding the use of masks, which is not yet very explicit by the WHO at least, and other measures is really important. We continue to engage in these. Now, it is two things: consistency in doing these things, and also ensuring that the greater majority of our population are following these guidelines. Because what would happen is that if, for example, you and Titus in the studio right now, if you were doing your best, doing your social distancing, doing your hand washing, using your sanitizer, using your mask, and so on, and Titus was not doing that, what would happen is that it would negate entirely your efforts. So the more we all do this, the cumulative benefit to the entire population is huge. And this has been proven by research. I can speak a bit to the mask issue, and there's a raging debate in academia, in the public health world, regarding the utility or otherwise of the mask. There is some evidence. For now, it looks like there's more evidence tilting in the direction of the utility of masks. But from a public health standpoint, what we argue is this, that while it may not be fully conclusive as yet regarding the utility of masks, there is more to gain if it was effective than not to use it. Some people argue that the use thereof, if inappropriate, actually increases the risk. This is another argument. But the current thinking of the position right now is that if there is something to benefit from it, let's use it. And I can tell you from where I sit that the evidence is tilting in the direction of masks being useful. I will personally, and again, I say this personally, not be surprised if the WHO within the next week or so, even a couple of days, comes out to say categorically that the mask may be useful. But again, let me reiterate, this is my personal view.
What do you say about the measured lockdown so far? There are experts I have listened to who seem to suggest that 2 weeks is just not enough.
Yeah, Samson, this is an issue that is very dicey, and you know, the first time I came in your program, I mentioned that we will applaud all efforts by the stakeholders, government, and others at addressing this problem. And where we need to criticize, as an academic, I will not shy away from criticizing. I believe that the 2-week lockdown is insufficient to achieve any significant gains. I think it was a good start. Maybe it was a measured approach. Let's see how this 2 weeks is going. Is it working well? If it's working well, we push it a bit further, or we titrate it a bit differently in different places. But on a general scheme of things, 2 weeks would be insufficient to achieve any significant gains. In fact, you might not be able to measure any significant gains. And if you watch what's going on all over the world, in especially Spain and in Italy, what they saw after the lockdown was actually an increase in infection rates and actually an increase in deaths. This does not suggest that the measures are not working, because it's only after about a month plus that now you can see a decrease in infection rates, and even in Italy now a little decrease in the death rate, even though in Spain actually the death rate is not changing very much. So this should tell you that it takes time for a lockdown to be effective, and the one thing that must go along with a lockdown, of course, we've mentioned this ad infinitum, is the testing. If you don't combine this with the testing, then your lockdown is pretty much inflicting economic injury on your own self without any gains.
So we knew at the time that we were locking down that we had what elsewhere they would say is quite a bit of an insignificant number, even though an earlier lockdown measured would have been prudent, using the hotspot. Now we know that we have gone to 205, and there are certain places that at the time we were choosing the places to lock down had not had recorded an infection. Now there are new places that have come on board, correct? What should we do?
Well, that's another really great question, and you invariably provided a sneak peek into what the answer would be when you said some places have not recorded. The key word there is recorded, which is we have not seen, we do not know, but it is clear that the probability is there. And in fact, the evidence that the probability is there is that even though the lockdown was in place in places like Accra and Kumasi, we saw cases pop up, or we've seen a case pop up, at least most recently, in the Upper East region. So that should tell you that we only didn't have the eyes to see. Now, if even after a lockdown in these two places, we had a case popping up in a place that did not have a lockdown, and so to speak, is not interfacing with either of these two places, it should give you a sneak peek into what might be happening in the places where we know there are cases, even if there was not a lockdown. So I think there's sufficient evidence to show that the lockdown is necessary, but the key is that it must be combined with all the efforts that would help us to identify the cases. So far, we're hearing that testing is going on. They're trying to identify contacts and all that. This must be ramped up in order to make sure that the lockdown is as effective as possible, and also we can achieve the objectives within the shortest possible time.
And what do you say is the purpose and usefulness of the limited mass testing that is going on in Ayawaso?
Well, yeah, I'm not proximal to that activity there, but what I can tell you from my understanding as a scientist and as a medical doctor also is there are limitations to how much testing we could do. We have limited resources, and when you have limited resources, you've got to be very careful the way in which you use them so that you can get, as we say, the best bang for the buck. It may not be the loudest bang, but at least it's worth what you put in. So we clearly do not have enough tests to cover the entire Iowa. So what do? You try and limit these tests to those places, those areas, or that circumference within which you anticipate the highest numbers. And I think that is what is happening when you have limited testing. If we had our way, it would be great for everybody in this country to have a test when they want it. That's not happening anytime soon. When I say soon, definitely not within the next couple of weeks. Maybe a month or two down the line, tests will be widely available globally, and we can do this. Anyone who wants a test, go for one. But for now, limited testing is the only option. This must be done carefully, must be done scientifically. It may not come across beautifully in the eyes of the beholders, but the science is working behind it, and I hope it's being done right.
Right. Now, Dr. Breyuo, yes, we have Sheila Abeye-Bachman, who is in charge of the police public relations directorate. She will join us to share with us how things have gone so far. There's Nana Kwachi, who's been writing in very simple language to educate people, and he says that the lockdown will not reduce the total number of people who will end up getting infected. In the long run, either if a vaccine or cure is not found before it is over, fewer people will be infected and new cases will appear less frequently in the enforcement window. But there will still be some ongoing transmission. It will simply take a much longer time for everyone to get infected because movement is more limited and contacts less frequent. What a lockdown represents in reality is a stalling tactic. It will limit the rate of new infections, but its effects will not be felt for at least 2 more weeks. When we lock down, we are simply saying we are stalling the rate of infections. And like you guys say, it's a numbers game. So is there not a good reason to spread the lockdown?
Okay, so I think I would again make reference to the point the Ghana Medical Association made when we called for the lockdown. We called for a nationwide lockdown. People didn't understand us and we were criticized. And it was based on projections that we had done. And we noticed that, yes, you may have a few hot spots, but if you lock down, there are still people who may be in these other areas that are not hot spots. That will eventually show. It's just a matter of time. Be that as it may, you know, the decision to do a lockdown is more broader than just the epidemiology or the medical bit, because there's economy, there's social, there's cultural, and I think the president's team looks at all of this and they make a decision. So we have to make do with what we have. The lockdown is certainly beneficial. I mean, I am privy to data on how the cases are distributed and what informed the mass testing in Ayawaso. It is backed by science, and so far, my information I'm getting is that even the yield in this mass testing is quite low, which is very good news to the scientific world. I mean, when I mean yield, how many people are actually testing positive in that group of mass testing is very low, and that is a good information for us because it was informed by how much community spread is going on there. And then they do this mass testing and the numbers come low. Indeed, the WHO says it, and we all know that when you lock down, what you do is essentially you buy time as a country to be able to organize yourself because you reduce the rate of spread. So it is not that it's not beneficial, it's definitely beneficial. If not, we will not subject ourselves to this. And in our situation, the lockdown combined with the enhanced surveillance and testing is giving us a very good picture of what is actually happening on the ground. I should say we are not surprised by the continuing rise in cases. It's a numbers game, but we are not surprised. We actually expected it. We expected it because we were not testing as much. And so once you begin to test more people, you are likely to pick up more people who have it. What should concern us is these new cases that we are picking. How is the spread in the community? Does it portend to a bigger spread in the future, in the next few days? And then what is the disease profile for a clinician? If we pick up 1,000 people and they are all mild, recovering on their own, none getting to critical, we are excited about it. The minute we begin to get more people going into that severe to critical phase, that's when we get worried. Our system can cope with 1,000 mild people. We are not bothered. But if we have 100 people in critical disease today, needing ventilators, needing respiratory support, that is when the system will be challenged beyond its limit.
The Ghana Health Service Board says immediately we can take care of 200 at least. We have we can marshal 200 ventilators to support people in critical need.
We pray we never get there. These 200 ventilators is both public and private. Each ventilator requires a level of expertise to go with it. So do we have 200 of that expertise? In fact, if for each ventilator, perhaps we should have double the number. So if you take, let's say, doctors who are trained to handle and put people on the ventilator, for each ventilator, even if you assume that a doctor should do a 12-hour shift, you need at least 2 doctors with that skill to be on each ventilator. So we don't want to get there. We've seen the very well-developed health system crumble at that stage. What is happening in Italy now, what is happening in the US, in New York at some point, the president instructed 4,000 ventilators to be sent to New York City alone. But we are seeing what is still happening. So our best bet is to catch a lot of the people very early, deal with them, so that we don't get to that point where we are having that number of people. I think we should not be too excited about how many ventilators we have.
Well, the Ghana Health Service and the Information Ministry has also pointed us to ventilators in the ambulances. What's the significance of that to COVID-19 treatment?
So the ventilators in the ambulances are only as helpful in transport of patients. Okay, they are transport ventilators. They are not designed to have somebody on it for hours. So what that means is if you pick up a COVID-19 patient who should, by the nature of the disease, we don't expect the person to be in severe disease at home. But should somebody have respiratory distress while at home and you put them in the ambulance, it means the ambulance can support their give that ventilatory support till they get to the hospital.
All right.
But the major care should be on a proper ventilator in hospital. So we cannot be too happy about ambulance ventilators.
Okay. We'll speak to the police shortly to try to check how people have been complying or not complying with the measures for the measured lockdown. But let me get back to Dr. John Amoisi. I am on the Facebook wall of the Upper East Regional Minister, and that's where I am from. She says the Upper East region, that's 11 hours ago, the Upper East region has recorded its first case of COVID-19. A 33-year-old woman with no travel history out of the country. She however traveled to the Western region for a week and returned to Bolgatanga on the 27th of March. On 28th, she presented herself to the Upper East Regional Hospital with symptoms consistent with COVID-19. Samples were sent to Kumasi for laboratory confirmation. On the 3rd of April, the Ghana Health Service received the laboratory feedback indicating a positive result for COVID-19. Out of 20 cases so far investigated, the patient is in good condition and under isolation. Contact tracing has been initiated. The general public is urged to remain calm. There's no need to panic. Thank you. Signed, the regional minister. How should I interpret this information? Yes, Dr. John Amoisi.
No, sorry. Can you hear me now?
Yeah.
Yes, I can hear you.
Great. So I think the information provided by the minister is really poignant, because if you try and dissect it, he tries to give you a history of the individual leading up to the diagnosis of COVID-19 that has been made. But in our science, in trying to understand the transmission of disease, there are a lot of things that don't allow us to see the full picture. And here he made mention of no travel history and no history of contact with someone who have the disease. Now, we have something called information bias or recall bias. That's another bias, which is the ability of the individual to recall where they've been, their movement. Of course, when it comes to travel, one could certainly remember if they traveled, outside of Ghana over the past couple of weeks. So that may not really be an issue. But remembering everyone with whom you came into contact is really difficult. How can she tell if she did not go to the same hair salon as someone who had returned from the UK, from Norway, from Switzerland, or from somewhere else at some point in time in the week? How can she recall all the people with whom she came into contact, and does she know the history of those individuals? And the science is telling us that already in the US, we're seeing about 20% of those who have the disease being asymptomatic. In Ireland, we have about 50% being asymptomatic. What that should tell you is that there may be a whole bunch of people walking around with the disease showing no signs and symptoms, and we may be interacting with them. This, again, reinforces the need for the social distancing, or better still, the physical distancing. So we cannot tell. We cannot trace where she may have got this from. What we know is that she has it. And what we know is that she's at risk of transmitting this, and the right thing has been done by isolating it. What this should tell us is that this disease is real, and anyone is potentially at risk. You look at her history, and she seems, quote unquote, clean. It just shows that anyone can get this, and the right thing is done by all of us to ensure that there is this corporate overall benefit to everyone.
Okay. What did you want to say briefly about that? She went to Takwa, then came back to Bolga, and she's got it. So what are we doing to these places? So what must be done?
So my point is that it emphasizes that this is community transmission, number one. Number two, because we are not making public who the infected cases are, we only mention numbers and never individuals. So it is difficult for you, even the individual, to know if you've had a contact with an infected person. So usually that history is challenging. And it's one of the things we have been calling for the health service, not to disclose the identity of the patient, but at least make the data on the distribution of this disease available to the clinicians with a hotspot map to help us make the diagnosis. The person can say, I don't remember having any contact, but if he has gone to Takwa, we know there is a reported case, at least 2 cases in that part of a town, confirmed, who have been managed at home. We don't know who the other contacts are. So is it possible she has made contact with somebody who has and do not know? Okay. Again, the fact that there are asymptomatic people, like Dr. John mentioned, is a major concern. A lot of us will encounter people who have the disease and will not know. So we should just see the next person as a potential carrier of this disease.
All right. And the state continues to take measures that it feels will help to protect this country from further spread, particularly with imported cases. To that end, the breaking news is that the President, Nana Addo Dankwa Akufo-Addo, has, by a new executive instrument, EI 66, extended the closure of Ghana's borders by another 2 weeks, effective midnight. And the Information Minister, Kojo Oppong Nkrumah, says this is to ensure that the risk of importation of COVID-19 cases will remain curtailed while we focus on the enhanced tracing and testing program currently underway. And then, as he has done over a period now, he says we continue to thank essential service providers who are at the front lines of this COVID-19 response program. We also thank the people of Ghana for their cooperation thus far. This too shall pass, he says. Amen. Amen. Let's go to Sheila Abeye Bachman. And she is in charge of the Public Affairs Directorate of the Ghana Police Service. Thank you very much, Sheila, for joining us once again.
Thank you, Samson.
Right. And we are grateful that you made time to join us. I can appreciate that it's been a hectic week for you, as almost all media houses are pulling you here and there, asking you for an interview. It must be that difficult, isn't it?
It is, but I mean, we are used to it. It's our job.
All right. Okay. So the compliance so far, and the police, together with its allied officers on the grounds enforcing the measured lockdown, how would you assess the success or otherwise so far?
From our viewpoint as the security services, we think that enforcement has been satisfactory so far. Compliance, let's say largely, a lot more people comply, but there are some cases where people simply refuse to comply, and they endanger themselves and endanger the larger society by being out there and by not observing the social distancing rule. That we have worked out a plan that we continue to adopt to ensure that people stay home, that crowded places like the markets, people social distance so that they do not endanger themselves and endanger all of us.
Right, but how easy is it to enforce compliance, particularly as we know that there are many people, for example, who are in the food chain business who cannot show you, an ID card. There are people who are essential service workers who are going to work, as we have learned in the course of this week. They don't have ID cards. How is that working?
Our approach is to engage by stopping and questioning almost everybody we see. Through the answers that are given, we are able to determine whether the person belongs to the exempt group or not. And then we also make them aware of the risk involved in being on the streets and in being in a crowd, particularly at the market centers. Those that we do not find any good reason for them to be out there, we return them to their bases, or we ask them to return to wherever they are coming from, meaning we do not give them access. And so largely we engage and we try to persuade. But where these things fail, then they leave us with no option than to arrest and prosecute.
In the exercise of that discretion, is it not a very difficult thing to do? I moved out of my house and I needed to get some medicine, but there's a particular pharmacy I needed to get to. So driving, I got to the police roadblock, and the police officer asked me, I said, I'm going to get medicine. He had to just believe and trust that I'm going to get medicine.
So now what we're encouraging people to do is for them to buy medicine or food or beverages within their neighborhoods. Traveling is highly discouraged for trying to patronize or purchase some of these items, because I think the point is that a lot of the people do not appreciate the danger they put themselves into by going out there and by associating with others. So if you also continue, and if all other parties, particularly agencies that are mandated to educate the populace, come on board and they make us aware, as in Ghanaians, not the security personnel, they make all Ghanaians and residents in Ghana aware of the dangers involved in meeting others, they would stay home. So far, we have done a lot of education, we have done a lot of engagement. The media is helping to do such engagements, and we are hoping that as the days go by, compliance levels will be high.
Right.
It appears that at the residential areas, we see a lot more compliance. Where we are challenged now is at the market centers like CMB, particularly at market centers which do not or which are not situated at residential areas. People just come there, they want to buy food, and you try to persuade them to go home, and they do not appreciate that. So let's continue with the education. Let people know that the focus or the essence of the imposition on restrictions is just so we do not endanger ourselves, just so there can be room for medical personnel and for the experts to be able to contact trace, to test and contain or manage the positive cases,
Right.
so that those us or those who have not been infected will be safe.
So last week on this platform, you know, a retired army officer had concerns about what could be excesses in the enforcement of compliance, and you re-emphasize that it was a humanitarian policing job they are doing, and this is not a combat exercise, and therefore your officers had been sensitized to ensure that they do not, you know, do anything untoward against the citizens. There have been a couple of cases that you have not been pleased with. Where do you draw the line between they misconducting themselves and using the reasonable minimum force to ensure compliance for our collective good?
Samson, I think that you need to applaud the security personnel for what we have done so far. When you look at the level of non-compliance among some people, I think that we have done very well. We have been provoked and all, but we have still been able to maintain our cool.
Great.
What the Inspector General of Police and the leadership of all the security services tell their men and women is that accoutrements that are not used for enforcement should not be used. And those are the things we frown upon, for which reasons any complaints that come in that direction will be investigated. The couple that you mentioned, they have come to our attention and they are being investigated. But we are still focused on the exercise and the objective of ensuring that people stay home, people do social distancing, so that we can all be safe.
And when you say there are some accoutrements they are not allowed to use as police officers or security officers, what are you referring to? And these are people who are already sort of endangering their lives by getting in the forefront to help, and you put them in further danger of, you know, being suffering brutalities. We have seen situations where civilians have decided to attack, you know, men in uniform, and so if you take away their protection from them, are you helping them?
So it is important that you use your medium to tell people that they do not have to endanger the life of a police officer. I keep saying that if we are not able to defend ourselves as security personnel, whether as a police officer or as a soldier, then it means that we will have no energy or no life to defend others. So it is important for people to understand that they do not have to provoke a security personnel just so the security personnel will be will employ high-handedness only to either divert focus or attention from the objective of the exercise or to get the person into trouble. No. But like I said, such cases will be investigated. It does not, and it will not divert focus or attention from the fact that we want to enforce the law to ensure that we are all safe.
Okay. Finally, what do you have to tell people yourself? What message do you have for them as you get in the front line with all your officers trying to assist in this direction? And of course, some officers whose work have been captured by the media or individuals are getting the needed applause. There's this army officer, is it Michael Infum, who was seen, educating people, being very, calm about it, and everybody else is applauding him. What will be your advice to your own officers and also to the public as you continue in the next week?
To the security personnel, police officers and soldiers out there, thumbs up for the yeoman's job. We have a week or so to go, and you know that the morale is high. We aren't going to relent. We are going to scale up the exercise to ensure that everybody complies and to ensure that Ghana is safe. To the people out there who are listening, if you do not belong to an exempted service, or you are not an exempted service provider, such as an essential service provider, please stay at home for your own safety and for the safety of all Ghanaians. You do not know who may be infected, and you may not even know if you yourself are infected or not, and then you end up getting your family and friends infected and getting almost everybody else infected. So please stay at home as we security officers stay outside to give protection to the other frontline officers like the medical personnel to be able to provide the needed service that we need. Please stay at home.
Do you have the number of people who have breached and have been arrested and are being processed or being prosecuted? Do you have that number?
In terms of statistics, we would be able to give you all the numbers at the end of the exercise.
Are there some who are already being put before court?
Yes, there are some that I know across the country, but I won't be able to put a figure to it.
Okay. Very finally, I said finally, but very finally, this small bit, I say small, but it may not be small. Lawyers are not exempt. So those you arrest, how do you process them for court? They don't get representation. What happens?
Lawyers, we have been told, essential service providers, we think that, and the presidency and all the players involved in this enforcement are aware that not every right of the citizen is being curtailed, or the impositions are on some restrictions and not on every restriction. And so the representation by lawyers is upheld.
I see. I asked that question because it is the judiciary that is exempt, and the Chief Justice issued a circular, and in that circular listed the category of the judiciary that is exempt and clearly stated that lawyers are not exempt. That's why I asked. But thank you very much, Sheila, for all the good job you are doing, and we pray that you will be safe, and all your men and women, as you continue to assist this country navigate these difficult times. Thank you very much.
Thank you, Samson.
Right. Okay. So, yes, Dr. John Amwesi is still on Skype there. What would you say? There are some who say we are getting to a point where we are now likely to peak. Is there a science to that?
Thanks, Samson. It is difficult to tell whether we're peaking or not at this time. Looking at the graphs, it's clear that we're moving up, but you cannot tell whether you've got to the peak or not until you begin to see a sustained plateau or decrease in the number of cases you have. So far, we've been going up and up, albeit a little slower than we started out. So I do not agree with an assertion that we are at the peak. We are definitely on our way to the peak, but we cannot tell when we will reach the peak. It's also very difficult to predict accurately enough when we might get to the peak, given that you've seen the way the cases have been identified. We have, we had a bunch of close to 50 plus coming in at one go when the cohort of returnees was tested. We had a bunch of 10 from Tamale in one go. So this, moves the cases up really quickly and does not really give you an indication. We also not necessarily measuring the rate of infection proper. What we are measuring is the rate at which we are detecting the cases. So it's hard to say we are at the peak. I would shy away from suggesting that at this time.
Okay, and what can we do about this situation? It does look like it's almost unavoidable. As I read about what is happening in Italy and elsewhere, those at the front line, first responders, are all getting infected. But what can we do about it? We're told about a nurse at Kolebu Teaching Hospital that tested positive. We're told about the situation of a bit of a panic at the Tamale Hospital also. Those who are said to have come into contact with, someone. What can the state do to protect these workers? Because we don't have them in the numbers that we need in the first place.
A great question you ask, and I think there's two categories of frontline workers that the state has to pay very close attention to. One is the security personnel, really ensuring that they are well equipped and also protected, because these are people you are putting on the streets to interact with the few who move around. You want to make sure that our security personnel have their masks, have access to sanitizers, and so on. But moving specifically to the frontline healthcare workers, we have seen what is going on in a couple of countries, starting with China, where some healthcare workers, because of the nature of that state, actually resigned themselves literally to death because they were being exposed without the required protection, even though later on protection was highly available. We saw what happened in Italy, and more recently in the US, where some healthcare professionals have even resigned on account of unavailability of protective equipment, such as nose masks, face visors, gowns, and really simple, straightforward PPEs. We even heard of a story, which is actually true, of a nurse or two who have committed suicide in the U.S. because they felt that they had been exposed, and going home was going to expose their families and put more people at risk. It is suicidal to the entire nation not to be able to provide protection first and foremost to those who are facing the oncoming danger face to face. There must be a priority. Face masks must be in abundance without any reservation. The gowns for them to treat people, the gloves, and the face visors. So that's by way of personal protective equipment. The next step that we must move to, and I'm hoping we'll see this, will be beginning to look at prophylaxis for our first-line healthcare workers. I can tell you already that in the UK, they are starting a study looking at the prophylaxis of chloroquine or hydroxychloroquine in terms of being able to prevent the symptoms of COVID-19 or prevent the progression of COVID-19 or to attenuate the clinical severity of COVID-19 infection among frontline healthcare workers, because these are the people at greatest risk of being exposed, and any effort to identify what might help, they've decided to try it on them rather. I can go on to speak about chloroquine and hydroxychloroquine, but that's not the focus of your question. But I was just trying to point out that beyond providing the personal protective equipment, whatever can be done by prophylaxis should also be provided to the frontline healthcare workers.
Please finally speak to the question of the chloroquine that you referred to. What's the efficacy in using that to treat anybody? And we understand Ghana, there's a particular treatment that we are using.
Well, chloroquine is a really interesting one. I mean, it comes from the chinchona plant, which is really abundant in Africa, particularly in Central Africa, in the North and South Kivu provinces of the DRC, which actually are home to the largest plantations by far in the whole world for quinine. Quinine is a really old drug, was first discovered in 1820. Chloroquine itself was 1934. And then hydroxychloroquine, which is a more, water-friendly derivative of chloroquine, was discovered in 1946. So this is something that can very easily and very cheaply be produced. What we have known over the years, and this is not new, is that chloroquine and its derivatives are effective against viruses, and including coronaviruses. But this has largely been studied outside of the human body. Now, studies that are conducted outside the human body are very different from studies that are conducted in the human body, particularly because they act very differently, right? And some studies have begun looking at the role of chloroquine, hydroxychloroquine, and its derivatives in addressing COVID-19. The signs are encouraging now, but to wholesale suggest that chloroquine is going to be our savior and to recommend people to go for it is entirely wrong. In fact, the WHO has very, very categorically stated that it is wrong for anyone and any government to push the agenda of chloroquine en masse for its populations. Here in Ghana, the government has decided to start using chloroquine. I am not privy to the details of how this is being done, but I'm very, very, very concerned about the approach that was taken towards starting to use this, whether this is being done in the context of a clinical trial, which it should be done. I have not heard directly from the FDA regarding this, but I would like to believe that the appropriate processes were followed through with the FDA and that it did not come directly from the Ministry of Health, because it should be coming from the FDA. And I'm sure you've seen the letters that were written by the US FDA. The decision and the permission to use a drug was not made by the US government, it was made by the US FDA. And the same must be also in Ghana, must come from the FDA, because they have the skills and the right to do this. And so chloroquine is being used in different places. We're using it here. I don't know in what context. But beyond even chloroquine, there are other drugs which are available in Ghana, which are being used in clinical trials across the world. At least 70 countries have signed up for what we call the Solidarity Trial with the WHO. And in the UK, they have what we call the Recovery Trial. This involves a couple of drugs, Remdesivir, which is an antiviral, Bopinavir, Ritonavir. These are all drugs that are used for HIV/AIDS patients and are readily available. There's also interferon beta 1A, which is used to treat a disease called multiple sclerosis. And I'm just giving examples of medications which exist and which are showing promising signs of being effective, and which I think, if the Ministry of Health and Government is ready to play ball with those of us in academia and in research, we can very, very easily and quickly, with the FDA's oversight, deploy across our country and begin to see what works for us. And we need to start doing this quickly because time is running out.
Thank you very much. In a minute, what can you say in your language to people in your area and who understand the language that you speak, your local dialect? What can you say to them to protect themselves, Doc?
Yeah, I'm Fanti, so I'll speak Fanti. COVID-19 awabe oyada owo onye we friend story na bibia work kakeke. Na obia is at risk. It is a watcher and biara offer nose mask, offer sanitizer, offer there yahore and sound naze or de yetido, offer there yabetsne fie naze or de yetido. Because yetido a yenina obotum wakanina na yabazi. It's misrowing na the work can yenzidu torting na wetiye. It is the more canon.
Thank you very much, Dr. John Amwesi. Thank you very much indeed. And please stay safe. And thanks for your service to Ghana in this very difficult time.